Welcome to NeuroNoodle's Neurofeedback and Neuropsychology Podcast, featuring tech legend Jay Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle Podcast is supported by listeners and businesses just like you.
It's morning.
Jay Gunkelman.
So, Pete?
Boy, me and Anthony last night were dancing.
Well, Anthony's probably a good dance partner on that in that respect. He's got a lot of bits and pieces, and quite often has pieces of what he's talking about that have some value. So,
Dr. Marie Swingle, yay!
Hello. Let me just get my volume here.
Tasting, 1, 2, tasting,
Hi.
tasting.
What happened?
Hello,
Hello.
hello.
Hello, hello.
Am I back?
You're back.
Yeah, I can hear you.
Can you see me?
I can see you.
You're seen.
Wow.
See?
Oh, now
Here.
it's asking me to
Good.
leave the meeting. Wait a minute. There we go. Okay.
Last night you guys had some good questions, apparently, huh?
Oh boy, we got stumped left and right. And what are the common EEG patterns or phenotypes associated with side effects from neurofeedback? Side effects was a big one that kicked off the show. That took about 20 minutes. I threw in my regular headache, and that's all I had to contribute, Jay.
So,
Types of side effects.
Side
That's a
effects.
bit of a contradiction already.
if you're looking at phenotypes that predict side effects in neurofeedback, you'd end up having to look on every single case and what happened with it to figure out what, was it a incomplete assessment, or did somebody pick a wrong protocol, or was the person responding in a different way because of some medication or metabolic things? Every single case is different. However, there are phenotypes that predict failure in medication and other treatments. And I think that knowledge is probably the best answer to that question, because the answer of everyone is different isn't a very satisfactory answer. So in medication treatment for psychiatric purposes, the most likely thing to make the doctor pick the wrong medication is an unexpected epileptiform burst in the EEG. This is actually data from over 1,000 patients, and these were patients that had been referred from psychiatrists that had tried to medicate and came to a failure point. Can't figure this case out, send them to this doctor to get figured out. So when they came in, their EEG patterns, these are medication failure patients. So they did an analysis, cluster analysis on that data set. So the number one cluster was epileptiform content in the EEG. And if you're treating somebody for a psychiatric condition and what they have is an epileptiform discharge, you probably don't have the right medication. You could have an antipsychotic or a stimulant or an antidepressant, all of which drop the discharge threshold, and you make them worse. So an easy one to understand, at least. The second most likely to fail was beta spindles, which is another phenotype. Beta spindles are generated in a couple of different ways, but they're a cortical overarousal, and they're usually not assumed to be there. As an example, depression can be right frontal beta, not left frontal alpha. And if you've got that beta subtype, it's not the one that they think you've got. You go to a TMS practitioner who takes the story of your DSM. Oh, I have intractable depression. I tried a bunch of stuff. It doesn't work. So point that magnet at me. Where are they going to point it? No, if they don't do the EEG first, they're going to point it left frontally, assuming you have alpha. If they stimulate there and you've got beta on the right, they flip you to a bipolar or a manic state. So beta spindles being present predict medication failure and treatment failure in a lot of circumstances. It's an unexpected hyperexcitable cortex. And after that, focal slowing, which is some focal problem. It's not a normal psychiatric circumstance. It's a local lesion of some sort. And then low voltage slow, which is toxic or metabolic. And you're assuming it's a psych patient and they've got something, mold or uh, um, you exposure to some environmental toxin. And there's more and more of that all the time.
First, with shameless promotion, at APB, we're doing Saul Rosenthal, Rick Gevertz, and myself are doing a session called Crappy Cases, resurrecting something that used to happen years ago.
Yeah.
It used to be called train wrecks at the time.
Yep.
So we're all like doing one of these, yay, we're so fantastic, we know everything about everything, and we all forget that there are crappy cases. I hate the word train wreck, but there's sometimes where things just don't go the way we want to. And I think it's really, really important. So Jay pointed out the spindles, he pointed out the Epileptiform, but then there are certain, dare I say, personality types that actually go with specific phenotypes and or life history. And I think those you have to be really, really careful about. So I would say we're talking about abreactions. So individuals that are extremely hyper aroused, and there are many ways we can look at that in the brain. But when you try to quiet, the person cannot tolerate the quieting. A key one, I'm going to be a genderist here, but females who have had childhood trauma, a pediatric sexual assault is a good example. The rate of quote unquote abreaction and treatment failure with quieting protocols is through the roof. Another one is when we're dealing with personality disorders. I have a fun line that's not so fun, which is love me, hate you, let me bait you. So these are our clients that they really want you on side. They're very, very flattering. And then they poke and poke. It's kind of like these self-fulfilling prophecies of turning the therapist against them. And then, of course, the client turns around and attacks. That's a very, very specific profile for somebody in a very specific state of mental discomfort, dare we say. And look what's happening with beta and these individuals. So I think this is where you have to put on your therapist hat, your standardized therapist hat, as well as your neurotherapist hat. Look how the person presents in the quote unquote personality, and look at the EEG and wield these together with the finest tooth comb and subtleties.
Yeah. And a lot of times people coming into the field for treatment in some fashion go to a practice that is very good at one approach. And that approach may be perfectly appropriate for one segment of the population, but this client may be just outside of what they're really well targeted for. And if that's the tool they have in their tool belt, if it's a hammer, the rest of the world's all nails. And if you're a screw, you're screwed. It's not the tool for you.
Yeah.
And you have to realize that neurofeedback is a general term, like the term medication. Well, geez, what kind of medication? Is a stimulant or an antidepressant or an anticonvulsant or a sedative or what is this? Is this LSD? I mean, what the hell kind of treatment is it that you're seeking? And the therapist that you've found needs to have the tools that match with the presentation.
And how they use and don't use the tools. And this is where I'm going to get in that the bloody thresholds, that automatic artifacting and automatic thresholds. Sometimes it's literally the speed that an individual's brain can tolerate, or the pressure going into colloquial language, that a person can quote unquote tolerate. And when you just push these buttons of specific programs, boy, oh boy, are you potentially in trouble.
You know, auto thresholding can defeat the operant principle.
Bingo.
Now, Pete, you know high jumping. It's a routine sport kind of thing.
I got no
People,
hops.
you may not have been a high jumper, but you saw them.
Yeah.
And if the auto thresholding would set the bar lower every time you didn't quite make it, do you think you'd get any better? I mean, every time you didn't make it, it would go down and down and down. You'd
Mhm.
get pretty damn good at clearing it because it would have been down at your freaking knees. But the auto thresholding, the coach sets that bar there as a goal for you to exceed,
Yeah.
not as something that they think you should be able to clear easily. They want to stretch your capability, not have a guaranteed result.
And a
And
coach will know, continuing with Jay's metaphor, when you're tired. Okay, a coach will know if a muscle is tweaking. A coach will know, all of these very, specifics, to know whether they should push a threshold or let it go for the correct reason, not
yeah,
to, as Jay was saying, stop the
yeah.
condition.
And there's theories as to what level of thresholding should be set. And
Mhm.
if the theory is one that you expect to apply to everybody, the theory doesn't really account for everybody. Some people, if you give them a difficult task, they will knuckle down and do that any way they can. Others, they see a difficult task and they say, and that's difficult, I give up.
Yeah. Yeah.
And you've got to set your thresholding appropriate to the learning style of the individual. If they're frustrated too easily with a difficult task, you're going to have to give them a task that they can have some success with. You
Yeah.
can't set it as a very difficult level because it will frustrate them. So the percent reward ends up being something that people look at as a way to set the threshold.
Yeah.
And
Don't
the
just
the
look
percent
at
reward ends up having to do with how many of the inhibit bands end up stopping it just as much as the training bands succeeding. So it
And you
ends up
can't
being a
just look at
difficult
the
mix.
threshold. You can't look at the threshold success. You have to look at the change in the EEG. And I think a
Yeah.
lot of us get caught in the threshold success. That's a really good recipe for failure, I would say.
And then the next question was, are there people that are resistant to neurofeedback, and what commonalities are there for the people that neurofeedback doesn't work for?
There are people that are resistant to therapy, just the approach avoidance, you know. Uh, uh, they know that they have to have something done, but the closer they are to actually encountering the thing that it is they have to fix, the more they want to avoid it. So there's an approach avoidance for therapy, just like there is with other things in life. And if the person is not really ready to encounter themselves, they'll be treatment resistant.
Yeah.
But then treatment resistance is common in any kind of therapy. Um, Alcohol and drug treatment is notorious for treatment. People sitting in the audience, wondering where they're going to get their next beer, as opposed to, trying to figure out how to stay sober. So,
Yeah. And I
um,
mean, there's stereotypes that we have to consider. They do have some truth to it. The adolescent, that's dragged in, by parents who really, really doesn't want to be there, and
that's common.
doesn't believe in it, and is really, totally against it. And I very, very bluntly say, hey, if you're on board, this works better. It works faster. You don't want to be here. You want to be doing this, that, and the other. Come on board, and we'll get out of here a lot faster. I also don't have any issue whatsoever, talking about placebo. I said, yeah, this was all placebo. Yeah, up, from 10 to 30%. If you could get 10 to 30% more for free, don't you want it? Hop on board. The other stereotype is a spouse that drags in the partner by the ear. Oh, I'm just curious. I don't know why. My wife sent me here, or my husband did. Those are very, very difficult clients to work with. So I suggest that people kind of play along with the pervasive attitude until you see a little bit of a switch. But if somebody doesn't want to be there, they don't want to be there.
Autism came up quite a bit. It's been in the news, obviously. In autism cases with high beta spindle activity, what are the most effective long-term training strategies? And for kids with severe sensory issues, what has been successful in reducing hypersensitivity through neurofeedback?
Well, first of all, autism spectrum is a spectrum. Not all kids in the spectrum end up looking the same. There's lots of clusters of different things. One of the most common things is unexpected epileptiform content. 70%, 70%. That's better than even odds. However the hell that phrase came up, I don't know, even odds, but nevertheless, 70% odds of having epileptiform content in the EEG. If you don't know it's there, you're not treating them properly. One study with over 1,000 people in the study did 24-hour EEGs, including sleep. They found 85%. So, if you're not looking at the EEG in the autistic child, you're probably missing out on insight as to what would be beneficial for treatment. There's pharmacological interventions, there's neurofeedback interventions, there are dietary interventions, there's all sorts of different things you can do to reduce the likelihood of having an epileptiform discharge in the EEG. And neurofeedback is one of the more effective approaches. Working with intractable epilepsy, we've got a series of 6 out of 6 seizure-free and medication-free. Maggie is on a little cheer group in high school now. She was like 8 years old. She's been seizure-free for 7 years, and was basically being discussed for brain surgery because they couldn't stop her seizures. So in autism, you need to look at the EEG. Beta spindles are a common finding, but they're not as common as epileptiform content. It's not uncommon for them to occur as co-occurrences. The beta spindles easily kindled cortex. The discharges are fully kindled. Yeah. So beta spindles are hyperexcitable cortex. There's a couple of different kinds of beta spindles. You can have beta spindles in the teens, possibly due to medication. And quite often your client is medicated. You can have it in the 20s, that's hyperexcitable cortex. And that's the kind that's really problematic. If it's an F2 beta spindle, giant sinusoidal beta spindle, F2, probably F for Fred Gibbs. It wasn't anything fancy, like Fujita's scale for, this is just F for Fred probably. But as giant beta spindles are hyperexcitable cortex, and you need to suppress those. If they're at CZ, you probably have insomnia. If they're more frontal, you probably have impulsivity, hyperactivity. And those are published studies. Martijn Arns and Swatsina and myself and Sebastian Ulbrich, and then Martijn did a replication of it with a different sample with more ADD kids in it, and instead of seeing quite as much insomnia, they saw more of the impulsivity, hyperactivity with the beta spindle. But they're different neurochemistry. The frontal beta spindles are more glutamate, and the CZ is more orexin, which is a wakefulness drive.
Hey everyone, if you're enjoying the show and want to help us keep it going, please consider supporting us on Patreon. Your support helps improve the content and brings on great guests and grow the show. Join us on Patreon at patreon.com/NeuroNoodle. But hey, if supporting financially isn't in the cards right now, no worries. You can still help us out for free by liking, subscribing, and sharing this episode. It really makes a difference and helps more people find the show. If we've earned it, hit that subscribe button and turn on notifications so you never miss an episode.
Well, I'll jump in as well, take it down a few levels. A couple of things. I know we're not supposed to discuss protocols. I don't want to, but you
That was on
really,
the list.
yeah, have to, check the theta SMR. I mean, it's just basic stuff. Okay. And a lot of work can be done just with generalized quieting. The other is what we refer to again as the hot cingulate. Okay. If you've got a really high beta ratio or high beta and high beta, which many people refer to as gamma sum, you've got a lot of work cut out for you. But as Jay said, everybody is not the same. But generally speaking, if you've got high theta SMR, high beta, or high beta sum, you're going to hit some walls. So those are definitely things that you want to look at. The other is, in terms of sensitivity, all wonderful, get, full capping here and there. I don't know about you, Jay, but when you have a really sensitive child with autism, the chance of getting one electrode on in the first session is considered a grand success. Yeah, so I mean, you have to be really realistic with the parents. One of the things we do frequently is chat and send people to the dollar store, get those old-fashioned clip-on earrings, train, scrubbing with wet Q-tips at home, put a little bit of jam in there as well, like literally jam. Habituate the child to the best of your ability so that when they come to see you, you can actually get a reading. So I think that we really have to dial this back a lot. Really important to talk about all these fantastic specifics, but you have to be able to get a reading.
Yeah. Don't throw away your old caps. Send them home as practice caps for the kids to wear for fun.
Yeah.
And reward it. Anyway, the autism first recording that we get from practitioners that specialize in autism is still 19 channels. However, we expect it to be typically eyes open only. You can't get them to cooperate to close their eyes. Trust me, close your eyes. Right, and we have them run extensive, longer than normal sessions because there's going to be pieces that are just not good at all. And the thing that has allowed us to use the EEG on very difficult to record cases is the ICA cleanup. If it weren't for ICA cleanup, we wouldn't be really able to handle that kind of initial study even. However, done properly, ICA gives us nice, clean data. A lot of the big pieces of an extended study are thrown away because they're just totally artifact. But they're shorter pieces that end up being nicely cleaned up, and you can give valid interpretation and guidance based on that. And we've got a long-standing history of good success. Greg Charbonneau just sent a note to me a few weeks ago that he just completed his 2000th session. The 2000 clients that we had done to get together. So,
well, here, let me run over the protocol questions and everything. The first words out of my mouth, if I responded to anything, was "it depends."
Yeah, that's your sponsor, isn't it?
But how should practitioners determine the correct montage and protocol, especially in cases involving beta spindles or subclinical epileptic discharges? The idea of using a very short training durations, example, under 10 minutes for sensitive clients came up, worth touching on.
Short sessions are okay. You don't want to push somebody past their capacity to tolerate the sessions. As far as the first part of that, you had too many parts strung together.
How should practitioners determine the correct montage and protocol, especially in cases involving high beta spindles or
Yeah.
subclinical epileptic discharges.
No matter what EEG you're looking at, the standard for interpretation suggests that you use more than one montage so that you can actually check the perspective. One montage gives you one perspective. If all you saw was the front view, you wouldn't know what the profile looked like. So you've got to actually change your perspective, use more than one montage. Now, Nunez recommends against using linked ears. Now, there are people that recommend using linked ears. Now, that's an authoritative thing. It's like my two younger sisters. Yes, it is. No, it isn't. Yes, it is. No, it isn't. That's an authoritative argument. Agree with one or the other is their authority. There isn't any objective way to decide. Well, we actually have objective ways to decide. We have data that can end up making the outcome real. But we basically need to end up making an assessment, 19 channels, one for each of the 10-20 system as a minimum. Dropping down to fewer than that, you can miss. I mean, which electrode spot is not important. If you survey, you're going to get some information, but you don't get time linked information. And paroxysms can happen briefly. You only have a half a chance of seeing one in a 20-minute study for a known epileptic. So you've got to pay attention to the technical aspects of the EEG. Short recordings aren't as useful as full 20-minute studies. 10 minutes eyes open, 10 minutes eyes closed. And you'd say, well, 10 minutes eyes closed, yeah, but they fell asleep. That's part of what you need to find out. How fast did they fall asleep? If you fall asleep faster than 5 minutes, you just qualified for a sleep study, a nocturnal sleep study in a sleep lab. They do a screening, a multiple sleep latency test. You get 5 naps in the afternoon. They only hook up your EEG. They don't hook up for breathing or body position or muscle tone or snoring. None of that. They just look to see how quick do you get your vertex sharp wave? How fast do you hit stage 2 sleep? If you have a precipitous descent into stage 2, you can't stay awake, which means your sleep at night sucks. And if your sleep at night is that bad, you fall asleep fast during the day. They're looking in a sleep lab for disorders of excessive sleepiness. That's their bread and butter. You have apnea, you have restless legs, you have circadian rhythm delay, you have something messing up your sleep at night.
Jay, a little bit of a sidebar. I know of folks that I just always used to hate them. Head hits the pillow, non-issue, can nap like this during the day. And they seem to be really happy and fine. And yet we talk about this as a sleep disorder. What are the long-term effects of being able to go into stage 1, or essentially jump stage 1 and go right into stage 2 sleep on the long term?
If you're falling asleep precipitously and you're not going through normal sleep staging at night, your sleep at night, those stages are important stages. Each of them have a purpose. In the first half of the night, you get most of your slow wave sleep. Your pituitary, assuming you have one, is producing growth hormone. And that growth hormone allows your dendritic sprouts to sprout. And they have little spines that extend, and the spines get spinier, and your dendrites are hooking up, and you're creating a new connection you didn't have in the morning. And so by the next morning, you've got a new connection. Now, that new connection is grown during slow wave sleep, but it's got information played back through it in REM sleep. When you play back your experience during the day through the new connection, you're long-term potentiating what you learned during the day that was short-term recall. So if you want to actually efficiently learn and sustain your learning, if you learned 5 things today and tomorrow you only remember 2, it's not going to work so well for your long run. And if your sleep stages aren't intact, you're not going to have proper um, uh, uh, memory consolidation is the technical term for it, but it's literally growing new connections and playing back memory through it so that it is there for you long term. And um, there's too many people that end up starving themselves for total amount of sleep, and they end up being very sleepy during the day. They're restricted. Oh, well, I can stay up till midnight. Well, I still got to get up at 5. So you get 5 hours instead of like 8 hours or 7 hours, and that creeps up on you. Um, and there's some evidence that if you're severely sleep deprived across time, that it takes about that same amount of time of good sleep to really fully recover from the negative impact of it.
Thank you,
So
Mr. J. And I think, it's really obvious in terms of the effects with children and school. Yeah. So when kids just fall asleep really quick, sometimes it feels really good for the parents, but it might not be the best thing. The other thing which we haven't mentioned here is alcohol, in terms of the alcohol-induced sleep. Be really, really careful about that.
yeah, it's alcohol-induced ruined sleep.
Yeah, alcohol-induced
So
non-sleep. Yeah, let's make this perfectly clear.
yeah,
Passing out, not sleeping.
it ends up enhancing wakefulness. The depth and stability of your sleep is disturbed. Now you may pass out, I mean fall asleep more readily, but the quality of sleep is disturbed. And unfortunately, most of the sleeping medications that are hypnotics ruin your REM sleep. Um, benzos are REM suppressors. And didn't I say like REM is where you play back memories and that helps you long term potentiate? Well, take a REM suppressor and see if it doesn't mess up your recollection. People who are on benzos for sleep that are getting neurofeedback are going to pay for about 30% more sessions because it doesn't consolidate as well. And, you know, if you're fine with paying 30% more, there's a store out there somewhere for you, they'll be happy to charge you 30% more. But getting your sleep together can save you 30%, 50% of the sessions that you aren't really needing if your brain was efficient in its learning. So,
Dr. Marie, we haven't seen you for a while. Thank you for coming back. Give us an update on your sleeping app and your other apps.
Oh, yeah, going great. I just presented the Brain Calm app, so the Swingle Sonic Brain Calm app at the BFE. And the sleep app is in full roll, and the next one we're hopefully launching within the next 4 weeks or so is the focus one. So yeah, check it out at swinglesonic.com. And again, everything we do rigorously tested on the EEG.
yeah. And the BFE is where?
This is the Biofeedback Federation of Europe, and this time it was in glorious Italy. Yeah, so we all ate too much and, oh no, drank too much. Slept well, didn't sleep well. Unfortunately, I lost my voice during it, so that was really amusing, but, managed to get through.
Jay, what's going on in October, my friend?
Well, other than it being my 77th birthday this October, we're having an extended birthday party. It's the only thing I go out for. Really, I don't get out of the house to speak of. But people come in from all over the world, and some domestically, but from all over the world, people pop into Sassoon City, and we can have 80 people face to face in the Sassoon City Yacht Club. And so we take over the yacht club for 3 days and do EEG presentations and kind of a general rolling party for 3 days. We finish it with a dinner and get people drunk enough to make donations for student funds. And
Don't know what you're talking about.
you know, This year, I think it's long enough to probably auction off for student funds. It's been a couple of years, and but it's we intend to have fun. I've got some challenge coins made for people who attend to end up being able to have as a little keepsake as an identity. They're made out of nickel, and they have images on both sides. And anyway, the group has all sorts of other knickknacks for the swag bag. There's always trinkets every year, and we've got good speakers. And I don't know that Santiago is going to make it in this year. We may have him do it virtually because coming into the U.S. is really not an easy task for people, and some of the international attendance has indicated that they'll do it as a live stream this year because the U.S. Border Patrol is not something you want to interact with. And given the news, I can understand why. But we've got some people giving it a good solid try. Silvana from Macedonia has taken the last month to try to get her visa approved for her to travel into the U.S. So we're going to try and get her in to do a direct presentation. She's actually a fairly major figure in European neuroscience. She's in the Macedonian Academy of Arts and Science, and she was a student of Jordan Pop-Jordanov, who taught me about quantum effects in the EEG. He was the head of quantum physics for the Soviet Union, and was in Macedonia when the Soviet Union kind of disassembled itself. So anyway, so we're trying to have a fun meeting. Lee Steinberg's going to be there to kind of give us a little perspective with the closing remarks at the end of the meeting, and that should be interesting. He's made his mark in the world, obviously, as a sports agent, and a very sharp guy, and has a perspective on traumatic brain injury. He has an annual meeting where neuroscientists and football players and other people that have had traumatic brain injuries end up having a meeting. So he'll have something to say about TBI, and so it should be fun. For EEG geeks, it's really just heaven, But for other people, it's just regular kind of fun too,
Networking of nerds, love it. Dr. Marie Swingle, Jay Gunkelman, thanks for another great episode of the NeuroNoodle Neurofeedback Podcast. See you next week. I'm fired up, Dr. Marie.
I'm sorry I couldn't be there with the group last night to fend off questions. However, I was meeting with all of the students that Mark Jones has that are doing their BCI, brain-computer interface dry sensor project, and talking to them about amplifier designs that are appropriate for dry sensors versus regular EEG amplifiers and things like that. So we had a good long technical session that
we take you whenever we can get you. Same with you, Dr. Marie, and then Mark Jones, what you guys are doing out there in University of Texas, San Antonio. That's intense. I love that 3D printing a cap. Woohoo! I don't know if Mind Media likes it.
We sent them a couple $1,000s as a grant. And most grants you have to apply for. Well, for a small grant, the application process and reporting afterwards eats up any value that there is in it. It's more of a pain in the ass to get that kind of a grant than it is for income. Yeah. So this is the kind of grant we gave. We saw, geez, they're doing some interesting stuff. We should send them a couple $1,000s. That's an angel grant. And angel grants are great because you get the money, You didn't ask for it. It comes out of like freaking heaven somehow. And at that point, you don't have to report back exactly how you used it. The assumption is we see what you're doing. You're doing good stuff. You need some funds. Here it is.
Do more.
Yeah, and I also just personally, separate from this Summit, sent him some money for student travel if any of the students want to end up making it to the event, and they'll live stream so that the students who can't travel or can't afford. I mean, even if you get a grant, you still traveling is going to come out of pocket somehow for a student, and that's not easy. So they'll live stream into the ones who can't make it.
And then for everybody, every Wednesday, 6 p.m. Central Time, show up, Q&A, ask questions. If we don't know, we'll tell you, but we'll find out just like we did today. Everybody, have a great weekend.
Take care. Bye, everybody.
Sweet dreams.
All right, bye-bye. The NeuroNoodle Podcast is supported by listeners and businesses just like you.